Good evening, everyone. My name is Dr. Vishal Soni. I'm a consultant laparoscopic surgeon based out of Ahmedabad, Gujarat. I welcome everyone for the masterclass on rare abdominal wall hernias that we've gathered today to learn and understand more about. I welcome all the speakers, the chairperson, the delegates, and all the viewers that are joining us live and who will be viewing us on the various channels later on. I would like to welcome Dr. Ramesh Agrawala, the president of Hernia Society of India, and I would want him to start the session with few kind words from his end. Dr. Ramesh sir, over to you.
Thank you very much, Vishal. On behalf of Hernia Society of India, I welcome all the faculty, namely Danny, Emil, Yusuf, Siddharth, Vijay Mittal, Atul, Harmeet, Ganesh, Pallavi. I'm sorry she's not there. Parthasarthi, Rajesh Kullar. All of you all, I welcome all of you all to this webinar. Pallavi was supposed to moderate this session. She was supposed to be there, but she had her uncle passed away yesterday, so she has gone there. So we are all going to miss her. The Hernia Society of India is very active, and we have a lot of educational programs. It is a very vibrant society in India, and the whole focus is to educate and propagate the art and science of hernia. So we request all of us to join us, join the Hernia Society of India, and be a part of this teaching and training. Now, without much delay, I would ask Vishal to take forward the proceedings. Thank you.
Thank you, sir, for the kind words. I would be starting this session with my views and thoughts on femoral hernia. That would be my topic for the day. Again, allow me to introduce myself. I am a consultant surgeon based out of Zydus Hospital, Ahmedabad. And in the next few slides, we would talk and discuss more about this topic that we have on the screen. The incidence of femoral hernia is in the range of 2 to 4%. That is when clinically they are operated. It's likely to be different in population, but this is what the surgeon comes across. We definitely know for sure that females have more incidence as compared to the males, but even then, the commonest groin hernias in females still remain inguinal hernias. But when it comes to femoral, the incidence is about 4 times more commonly seen as compared to the male counterparts. The cause of the femoral hernias, and more commonly in female, would be in part due to multiparity, anatomical issues like narrow insertion of the IPT into the pectineal line. Along with it, all the conditions that cause increased intra-abdominal pressures or pelvic floor weaknesses do contribute to the occurrences. Another point to be kept in mind is post-weight loss status. This is when the patients come in obstruction with no apparent hernias to be seen. Moving over to the anatomy of the area under consideration, the femoral canal is a potential space that is bound anteriorly or the superior aspect by the inguinal ligament, the posteriorly by the pectineus. On the lateral aspect, we see the femoral vein, and the medial border is formed by the lacunar ligament. Mind you, this is a potential space which then has a tendency to open up and the hernia getting developed. The importance of this anatomy not only lies in how the hernia happens, but also during the surgical manipulation and the surgical approaches. We'll see that shortly in the slides to come. According to the space from which the hernia starts and propagates, we have various eponymous hernias. When the initiation is through the lacunar ligament, we have the Logis hernia. When the hernia occurs behind the femoral vessels, we call it the serophony. When it happens in front, we have Thiel's. When it happens to the pectineal fascia, it's the clockwise hernia. Laterally, when it happens lateral to the femoral artery, it will become the Hasselback's. And when it happens behind the femoral artery, as in case of congenital dislocation of hip, it's called a Narad's hernia. Now, this is a view that is of utmost importance to the minimally invasive surgeon. This is the posterior view where various structure can very clearly be seen We start from the rectus muscle, which is seen in the left side of the screen here, which gets inserted into the pubic bone. We have the lacunar ligament, as I just showed you in few slides back, which is the medial part of the femoral canal. This is the potential space which we talk about as the femoral canal. On the lateral aspect, we have the vessels. In this particular image, we have the accessory obturator seen. Moving on further, we have the vas in front of us. We have the spermatic vessels seen. The iliopubic tract would be across the screen. And at 12 o'clock positions here, we have the inferior epigastrics. We'll talk more about the relevant anatomy and how it affects the decision making in further slides to come. There is this very beautiful paper by Maslow and the team, which gives a concept of an inverted Y and has divided the whole anatomy into 5 triangles. Based on defined anatomical landmarks, there are 5 triangles defined. So the upper limb, superiorly, which is formed by the inferior epigastric vessels. Horizontally, we have the iliopubic tract. Medially and inferiorly, we have the vas. Inferiorly and laterally, we have the spermatic vessels. Accordingly, to go from anti-clockwise, we have the triangle bound by the inferior epigastrics, the lateral border of the rectus muscle, and the iliopubic tract. This is where the direct hernias are seated, and this is where they propagate. Inferiorly, we have what can be called as a femoral triangle, denoted by the capital letter F, where the femoral hernias are seen. Bounded by the spermatics and the vas is what is called as an area of danger, doom, or death. We find the iliac vessels sitting at the floor. Between the iliopubic tract laterally and the spermatic vessels is the triangle of pain. The importance is that any fixation done in this area would lead rise to a lot of pain. Strictly speaking, the triangle of pain has a small extension superiorly by about 2 centimeters. I'll be mentioning the same in a couple of slides to come. This is the relevant anatomy that every minimally invasive surgeon should be very well versed with when it comes to identification of hernia, placement of the appropriate size of mesh, and the fixation of the mesh. This is the view that is seen when a laparoscope is introduced and all the anatomical landmarks that we just mentioned become very clear. Add on to what I just mentioned is the umbilical ligament here, the obliterated umbilical artery that is seen. That is the medial most margin from where the peritoneum division starts usually. And this is an overlap of all the triangles with an inverted Y that I just mentioned. We have the pubic symphysis as the medialmost end, the iliac crest, which is the lateralmost end, and the various letters denote what happens in that triangle. I would be for the indirect hernias, D would be for the direct hernias, F is for femorals, and the pain is for the occurrence of pain if there is fixation done in that particular quadrant. And the red triangle is where, if at all there is any manipulation or fixation done, it can lead rise to torrential bleeding. This is the interesting finding mentioned in the paper by Reinpold that I was mentioning about, where they studied the anatomical variations of all the nerves that we are talking about, the lateral cutaneous nerve of thigh, the femoral branch of genitofemoral nerve, and then they realized that the entry exits are way above the iliopubic tract, and therefore not only the IPT but even about 2 centimeters above the same, there should not be any fixations done. And that can be called as an extension of the pain triangle. This slide shows the surgical approach that one can take when they are operating the patient for groin hernia per se, where the step 1 would be dissection in the lateral area, followed by step 2, which would be dissection more in the medial area. Step 3 would be the pyramid dissection, the central area. What is shown is the structures that are to be taken care of in the particular area. So lateral, we would be very careful regarding the nerves present. In the medial area, we would want to define the pubic tuberculum, the ligament, and dissection of the hernial sac would happen. The central area is where the peritoneum is densely adhered, especially in case of indirect inguinal hernia, and it also has adhesions with the vas deferens and the vessels, so the dissection needs to be very careful. This is the picture once the dissection of the peritoneum is completed. The blue line represents the line above which the fixation should happen. The red line is where the inferior epigastrics are seen. And this is the triangle of doom that one should be very careful of and should be away from. This is my way of training and teaching my associates of having maybe a funny thing to remember or a better recall. That beak is where the lacunae is, and the head or the eye is where the femorals happen. So we have to make sure in each and every patient that the eye of the bird has been seen, has been noted, and we made sure that the femoral hernia was taken care of, even while we are doing an inguinal hernia. Moving on to the next portion, that will be the diagnosis part. Diagnosis not only starts with the clinical examination, but it starts from the thought of an experienced mind, of a carefully evaluated patient where you suspect that this patient might have a femoral hernia. The first step essentially would be a clinical examination. The usual way in which it is mentioned is that the femorals would start below and lateral to the pubic tubercle, and the indirect inguinal would be above and medial, although the dictum holds true in small hernias also, but this should not be relied upon totally. We'll see why. As clinical evaluation alone can miss a lot of hernias, especially when they are small, and more so in obese, when patients have a big pad of fat in their pubic region or in the groin area. Also, when there are multiple hernias seen, the most obvious one would be picked up, but the other ones might be missed. Challenging hernia diagnosis, the ones like in femoral or clinically occult hernias, should be further evaluated, and that happens using imaging modalities, which we'll be further talking about. Luckily, groin has a lot of well-defined anatomical landmarks, which includes muscles, vessels, and bony landmarks, using which we can very precisely diagnose which type of hernia we're dealing with, using the modalities of ultrasound and CT scan. What you can see on the screen on the left-hand side is the open groin here. I represents the iliacus muscle, T is the tendon of the psoas, P is the pectineus, L is the lacunar ligament, and F is the potential femoral canal space. The blue represents the femoral vein, and the red is the femoral artery. On the right-hand side are the various hernias we just talked about a few slides ago. Coming further to the basic, most radiological modality, the ultrasound. Femoral vein is one of the most important anatomical landmarks to be kept in mind while diagnosing and while differentiating a femoral hernia from that of an inguinal. None of the inguinal hernias would ever have a compression of the femoral vein, and this one aspect is utilized to differentiate that from the femoral hernia. On the left-hand side image, we have a femoral vein, lateral to which would be the femoral artery. On the right-hand side of the screen, here we have a large femoral hernia, lateral to which is the femoral vein. Although an obvious compression is not seen, but femoral hernias tend to compress the femoral vein. Moving on to the further modality, that is CT scan of the abdomen. Here, the femoral vein compression is seen very beautifully. The femoral hernia coming out of the femoral canal, and since it's a tight space, would give rise to some pressure on the femoral vein, which is adjacent to it. On the right hand side is the coronal view, showing the bowel loop which have got herniated into the groin using the femoral canal. And as compared to the opposite side, we see that there is presence of a well-defined hernia on the right-hand side. This CT shows a very interesting, although a rare finding, that is presence of an appendix with some free fluid in the hernia. This is the gangrene hernia. And again, CT scan would be the modality of choice to diagnose and to make sure that such a hernia is not missed or a surprise is not found when the patient is taken up for a surgery. This is a CT scan showing a femoral hernia on the left-hand side. This is the femoral hernia that we just be seeing. We can see the relation with the vessels here. Again, a coronal thing for the same. So originating below the iliopubis tract. And this is where there is some subtle ballooning also seen of the femoral vein. The video was shared by Dr. Sumanta De, a very good friend, and thanks a lot to him for the same. Coming further to the treatment part, femoral hernias need surgery. A blanket statement can be given, and it is very clear. Early elective surgery is the recommendation when compared to elective repair. When you wait and these patients, when they complicate, and they will complicate, it is associated with a greater risk of bowel resection and a longer hospital length of stay, as we see in a hernia search paper. There is a tendency that if the tissue repairs are done, the patient can be taken care of, but mind you, these patients would tend to have a higher recurrence rate as compared to the mesh repair, and therefore mesh use is recommended, especially when not contraindicated, when the field is not contaminated. A stronger statement coming up would be that laparoscopic surgery is recommended, especially when the expertise is available and there are no strong contraindications.
Hello.
The data is there to support that there's significantly less recurrence. The post-op pain is less as compared to the anterior approach, and it provides an opportunity to identify all the other hernias, and even the contralateral sites can be examined in the same go. If at all an anterior approach has to be used, it would be better if a preperitoneal open mesh plasty is used, whereby we put the mesh in the preperitoneal space, which gives a better result, a better repair, and lesser complications as seen by fewer recurrences and lesser post-operative foreign body sensations as compared to an anterior mesh. To further give information on the same, we have three approaches mentioned in the open, the classic ones, the Lothesine trans-inguinal approach, the Lockwood infra-inguinal approach, and the McAvee's high approach. The incisions are meant as I have shown in the diagram on the left-hand side. The concept would be to identify the femoral hernia, to close the femoral ring. We may or may not add a plug as the surgeon might desire. These are the operative images. This one particular shows Lothesine's repair, where the inguinal exploration has been done. The posterior wall has been opened, and we've seen the presence of a femoral hernia, which is then reduced. The sac is opened. The sac is then excised, closed, and a tissue repair has been shown here. Moving on to the better probably repair, and that is the laparoscopic. I personally prefer TAP surgery, so I'll be talking about TAP mesh plasties. On the left-hand side is the surgeon and the assistant placements. So the camera and the workstation comes on the side of the hernia, and the surgeon stands on the opposite side of the hernia. The port placement would depend on how the instruments and the triangulation is being conducted by the surgeon. So in the routine, what I would also follow would be that there'll be a triangulation of the instrument. The camera port would come in the center, and both the working instruments would come on the opposite side, as shown in the image here. We may also use ipsilateral ports, whereby the camera would be placed on one side and both the instruments are on either side. So it can be horizontally placed, it can be vertically placed. So these are the port placements, especially when it comes to bilateral tap mesh plasty. So the camera would come in the center and both the ports, 5 mm ports, would come a little lower down, placed symmetrically. But when we are operating a unilateral hernia, the port on the side of the hernia can be a little higher up, and the port on the opposite side of the hernia can be placed a little lower down for a better triangulation and for better ergonomics. Here is a video shared by Dr. Sarfaraz Beg showing a tap mesh plasty done for a femoral hernia. So we can see the femoral hernia in this aspect here. He's now opening the peritoneum. It should be done about 3 centimeters above the superior extent. Gentle traction, counter traction is the key for correct and beautiful dissection. The medial limit would be the medial umbilical ligament. The correct space would be the preperitoneal space. And what he just divides gives a small subtle hint towards the bilamellar structure of the transversalis fascia. He further goes down and does the medial dissection to see the lighthouse. Thin strands of the preperitoneal space are then divided. If the plane is correct, then all these can be done very beautifully with a scissor with minimal use of energy devices. And here is where he's operating at the pyramid. We expect little adhesions in this area. The long standing the hernia is, the denser the adhesions would be. And in this particular patient, since it's a female patient, we'll come across a round ligament. That's dissection at the ring. And shortly we'll see the femoral hernia. Yes. So he put his instrument in the femoral hernia from the peritoneal side. He'll define the round ligament. That's the round ligament that has been dissected. And now it is being divided. Fat would be then cleared. We will shortly see the nicely dissected femoral canal. Adequate space has to be created to place a correct size mesh. This is the pubic bone, the lacunar ligament, and the inferior epigastric artery. And this left instrument now goes into the femoral defect. Over here also, we do see an accessory obturator vessel. FR is the femoral ring. Very beautifully seen. The peritoneal opening is then closed. That is where the femoral hernia was. So as you can see, he is using ipsilateral instruments through ports placed ipsilaterally. The mesh goes in. The mesh is fixed at the bone. The suture is cut and it is unrolled to cover all the other sides of the potential sites of hernia. Another fixation done, and this would be closure of the peritoneum. It's done in running suture fashion. And we can see that he can operate from both hands. Very beautiful video. Another very beautiful letter to the editor, where Orgadias mentions 9 steps to critical view of for the myopectineal orifice, how to go in a very calculated and methodic way in which the dissection can be carried out for performance of safe surgeries and to detect even the occult-most hernias. To summarize, we should look for these hernias in all female patients specifically. Definition of the myopectineal orifice in all the anatomical landmarks is important to perform the surgery safely and correctly. Groin pain evaluation, this is how the patients present to us, especially with small hernias, need a dynamic imaging like ultrasound or a CT scan. Acquaintance with lap anatomy and imaging modalities is very important, and it is the way ahead. There will be no wait and watch as we do or as we might do in case of inguinal hernia. And all these patients would need surgical intervention because of high incidence of complication when the femoral hernias are conserved. And laparoendoscopic treatment is the preferred one. Minimally invasive surgery can be offered even in complicated cases, even when patients present with obstruction or so on and so forth. Thank you.
Thank you very much, Dr. Vishal, for that very wonderful illustrative talk. I now request the chairperson, Dr. Siddharth Tamaskar, a senior consultant surgeon in the Department of Minimal Access Surgery and GI Surgery, Sri Ramakrishna Care Hospital, Raipur, and an executive committee member of HSI, to just give his comments and any questions to be addressed to Dr. Vishal, please.
Yeah, first of all, Vishal, thank you for that excellent presentation and that elaborate anatomical depiction. It was really a wonderful lecture to watch. And I think femoral hernia is one of the more difficult cases of hernias where you have to tackle in these patients. Mostly they are missed, and usually in what our experience is that you usually find it in accordance with the associated hernias like obturator hernias and inguinal hernias as such.
Yes.
Another 1 or 2 things which, of course, I would just like to add on, because I also prefer to do I am a TAPP surgeon basically. So the other point regarding is when the mesh placement, because I'm talking about the laparoscopic hernia repair, is that we prefer to the mesh to be more medially placed in femoral hernias. If you're tackling a femoral hernia as such, and then at least a 3 centimeter overlap. Sometimes what happens is because the width of the mesh is limited to 15 centimeters, it may be a scenario where you're pulling the mesh medially and then you find that you don't have a proper lateral overlap, and in a few cases we have landed up putting in another mesh to cover up the inguinal part. So what is the take-home message is that the whole myopectineal orifice has to be covered sufficiently. At least 3 centimeters of overlap is what is important, and you have to go down below. And in femoral hernias, associated obturator hernias is common in our experience, So that area is also to be tackled. Of course, we are going to have an elaborate presentation on obturator hernia just coming up. And those are the take-home points. And I just welcome any other questions which I have. I don't see any questions on the chat. Right. You want to make any other comments, Vishal?
So I guess that will be regarding the obturator. As you rightly mentioned, we have a talk coming up, and that is where I left I would rather leave the topic to Dr. Ganesh. Dr. Ganesh Shenoy, I guess it will be over to you for obturator hernia, and Dr. Vijay Mittal, he'll be chairing the session. So welcome, Dr. Mittal. Welcome, Dr. Shenoy. Over to you.
So I'll start, sir.
Please go ahead, sir. Sir, please go ahead.
Yeah. Good evening, everybody. First of all, I would like to thank HSI, the Hernia Society of India, our president, Dr. Ramesh Agrawala, and all our executive committee members for giving me an opportunity to speak on this one of the rarest abdominal wall hernias, that is obturator hernias. Vishal had a wonderful presentation regarding the femoral hernias. So I would like to talk on, I've been given an opportunity to speak on this obturator hernias. So now, what is it? What is an obturator hernia? So by definition, the obturator hernia is the protrusion of either an intraperitoneal or an extraperitoneal organ. So intraperitoneal may be a small bowel loops, or maybe a colon, or an extraperitoneal organ or a tissue through the obturator canal. So this obturator canal is normally 2 to 3 centimeter long, and it is 1 centimeter wide. It is a triangular, normally contains obturator nerve and vessels, and obturator foramen is supposed to be the largest foramen in the body. So by definition, it is either a protrusion of intraperitoneal or extraperitoneal organ or tissue through the obturator canal. So by laparoscopic approach, how to define by laparoscopic approach? With the advent of this minimal access surgery, the incidence or the rate of detection of obturator hernias have increased. So which was so earlier called as an occult hernias have increased in incidence or the rate of detection because of this minimal access procedures. So by laparoscopic approach, there is a definition which to call as an obturator hernia. That is, excuse me, either the obturator foramen has to be wide, it's a wide obturator foramen through which there is herniation of peritoneal sac or a lipoma or a fatty plug which has originated in the pre-peritoneal or a paravesical or the parabladder, urinary bladder fat tissue. So the herniation of the peritoneal sac or the contents, intra-abdominal contents, or a extraperitoneal fat or a paravesical fat is considered as an obturator hernia through the wide obturator foramen. Initially, all the obturator hernias starts with the pre-peritoneal fat herniation forming a fat plug. Then finally, it draws in the peritoneum forming a peritoneal sac. Then the intra-abdominal contents leading to symptoms of pain or obstruction. So how rare are obturator hernias? It was first described by Arnold de Ramsel in 1724. So obturator hernia is one of the rarest hernias, with the incidence being 0.073% of all the hernias. It is slightly higher in the Asian population, about 1.6%. It is more common in females compared to male counterpart. The reasons being the broader pelvis, larger obturator canal in females, and the larger obturator foramen. The horizontal width of the triangle, the triangular obturator foramen, is wider in females. Maybe because of previous history of pregnancy, the multiparous woman tends to have a lax pelvic peritoneum. The pelvic peritoneum tends to become lax. So there is more chance of herniation of the peritoneum to the wide obturator foramen. It's been also mentioned as a little old lady hernias. The reason being this is very common in older females, more than 70 to 75-year-old females. As ages, there is because of emaciation, there is loss of preperitoneal fat and what we call as the corpus adiposum, which envelop the obturator canal. So this loss of preperitoneal fat, which was enveloping the obturator canal, results in herniation of the intra-abdominal or the extraperitoneal tissue, causing the obturator hernias. Now, obturator hernias, according to literature, are more common in the right side, it is thought that the sigmoid colon, which is there on the left side, normally blocks the obturator canal, so the incidence is more on the right side. Bilaterally, it has got incidence of 6%. But one point to be noted is obturator hernias are found to have the highest mortality rate among all the abdominal wall hernias. The reasons being, one, it presents at the advanced age, as called as a little old lady hernias. These advanced age people may have associated comorbid conditions, and the most commonly, the highest mortality and morbidity rate are because of its delay in presentation, diagnosis, and the treatment. Because it rarely presents as a visible swelling, rarely presents as a palpable mass, it is deep in location. Most of the times it is detected by perrectal or pervaginal examination. The classical signs which are described, like house-shaped rhombus sign, are very, very rare. They are just present in 15 to 50% of the individuals. Most of the obturator hernias, they present with pain, middle side of the thigh radiating to the knee. This is because the obturator nerve has got a geniculate branch which supplies the knee. So whenever there is an obturator hernia to the obturator foramen, where the nerve goes, there is compression of this geniculate branch of the obturator nerve, where the patient can just present with the pain. So there might be a delay in diagnosis and the delay in treatment. Normally, 90% of the time, this obturator hernias, they present as features of intestinal obstruction. So many times it is unsuspected that whenever the patient presents with intestinal obstruction, we may not think of an obturator hernia might be a cause for this obstruction. So there might be a delay in diagnosis. So whenever there is a delay in treatment, there are more chance that intestine may undergo ischemic changes leading to gangrene with the associated intestinal resection and anastomosis, which may add to the mortality in advanced age group. So early CT scan can minimize the chances of can increase the chance of detection of obturator hernia and minimize the chance of intestinal ischemia and mortality. So now, what are the approaches to be followed? It can, most of the times, if the patient presents with intestinal obstruction, it will be a lower midline laparotomy, which is most commonly followed. And the first successful repair of the obturator hernia by open technique was performed by Henry Ombre in way back in 1857. So whenever there is a midline, the basic principle of dealing with an obturator hernia is a lower midline laparotomy, then reduction of the contents, then resection if there is an intestinal ischemia, then the resection, then the repair of the obturator hernia. So if there is an intestinal ischemia or any gangrenous changes, it is not advisable to place a mesh, but to repair the obturator hernial defect. You can repair in many ways. Many a times the older literature and the recent literature also have mentioned using the surrounding tissues. For example, maybe a periosteum of the pubic symphysis, or a part of the urinary bladder, or the uterus, or the round ligament to plug the, or a vascularized omentum to plug the obturator foramen, so that the chance of recurrence hernia is less. But in an elective case, the use of mesh is a must. So these are the procedures utilizing the uterine fundus or the surrounding tissues like bladder or the round ligament. They may distort the normal anatomy of the pelvis, and also the introduction of the foreign bodies, for example, omental plug or any other foreign bodies, or a tantalum gauze, which was mentioned earlier, to plug the obturator foramen can compress the obturator nerve, leading to pain in the postoperative course. So some tips for successful repair of obturator hernia is the peritoneum has to be dissected well. It has to be dissected well to expose the iliac vessels. The reasons being, it enables the insertion of a bigger mesh or the entire mesh to prevent rolling of its free border. And it's very important, we should not trim the mesh, because if we don't trim the mesh, there is a greater surface area which is available, and it prevents the possible displacement of the mesh before the fibroblast can infiltrate the interstices of the mesh. And medially, the mesh has to be fixed to the pubic tubercle and the fascia or the symphysis pubis. So these precautions, if you have taken even in a laparoscopic repair, are set to reduce the incidence of recurrence in an obturator hernias. So I would like to go show you some of the video clips of obturator hernias. This is a young adult male who presented with the large left inguinal hernia. So it was a large inguinal hernia. We select cases for ET mesh repair. Only patients who have large inguinal hernias. So this was a large indirect sac which are lateral to the infraepigastric vessels. a high index of suspicion is required to diagnose these occult obturator hernias. So as the space of Retzius is dissected, or the cave of Retzius is dissected, once you give laterally, you can see some peritoneal fat, which is protruding into the obturator foramen. So by laparoscopy, by definition wise, any intraperitoneal or extraperitoneal tissue or organ which protrudes into the obturator foramen is considered an obturator hernia. So there you can see there, as we go lateral to the space of Retzius, we can see a suspicious fat protruding into the obturator canal. So this patient didn't have any symptoms of obturator hernia, maybe a pain to the knee or any other things which was mentioned in the literature or in the books. But this was instantly detected because of high index of suspicion. So whenever you dissect the entire myopectoral orifice of Richard and see a fat plug below the pubic symphysis, lateral to the bladder, then a suspicion of obturator hernia has to be. So you can see there that the fat plug, preperitoneal fat, herniating into the obturator foramen. Bipolar triathermy acts well in this situation to maintain hemostasis. That's the fat, preperitoneal fat, which was herniated into the obturator foramen. You can see the obturator foramen there. That's the symphysis pubis. So you can see the obturator nerve, the obturator artery, which are normal contents of the obturator canal. So whatever the preperitoneal fat which was herniated has been reduced, and it has to be ensured that the entire content needs to be reduced for the placement of a large mesh without any rolling. So this is a case of obturator hernia which was dissected during a TEP. So that's the left TEP mesh repair being done. The entire space of Retzius was dissected, and you can see again that the yellow marker, that's the fat, again herniating into the obturator foramen. So you have to be very meticulous, because here for reduction you can't give an external pressure. So you have to be very meticulous, because there are obturator nerve, obturator artery and obturator vein there. Take care not to damage those structures. So a gentle traction is of utmost importance in the reduction of these contents. There you can see there quite a bit of extraperitoneal fat was herniating into the obturator foramen. That's the pectineus muscle down. That's the obturator artery entering the obturator foramen. So intermittent use of bipolar diathermy to maintain the hemostasis helps to maintain a clean field. So all the fat which was herniated need to be reduced. Otherwise, you may still find some of the fat herniating behind the mesh, resulting in recurrence of the hernia, because you're not going to fix the mesh inferiorly. That's the obturator vein. You can see the pulsations of the obturator artery there. So all the fat has been reduced, and the obturator foramen is free of any contents now. That's the obturator nerve. And that's the Cooper's ligament. So this just to show that it will be below the Cooper's ligament, and as you go dissecting lateral in the space of Retzius, you may find a obturator hernia. So this again, around a 60-year-old male patient planned for a TAP mesh repair for a inguinal hernia. That's instantly we had all the 4 hernias. He had a direct hernia. He also had an indirect hernia. He had an femoral hernia and an obturator hernia also. So that's the direct hernia being reduced. That's the indirect sac there. So the indirect hernia reduced, and there was a suspicion because there was a preperitoneal fat which was herniating in the femoral ring. Normally during a dissection, we see that we also try to dissect the femoral ring, not dissect as such, just to go near the area of the femoral ring and find if there is any preperitoneal fat which is herniating, which was reduced. And here there was a suspicion of the fat going into the obturator foramen. So all the fat which is going into the obturator foramen is reduced. That's the obturator nerve there. So, as I mentioned, with the advent of laparoscopy, the incidence of these rare type of abdominal hernias have increased. So, this another case taken as a femoral hernia. Patient presented with the history of irreducible femoral hernia. The CT scan was done. CT scan showed features of femoral hernia. Then, since it was not reduced under general anesthesia, the patient was taken up for a TAPP mesh repair. The patient had previous history of cesarean section with lower midline scar. That's the space of red CS dissection being done. So the content, which was a small bowel loop, was already reduced. That's the preperitoneal fat, which is herniated into the femoral canal. So the preperitoneal fat is reduced. This is the anatomy of the femoral canal. Vishal has already explained. So as you go below, that's the Cooper's ligament. So with the high end of suspicion, as you go below the Cooper's ligament, you can see the preperitoneal fat along with the obturator nerve with a wide obturator foramen. So all the contents are reduced. There's a small obturator hernia there. So that's the entire myoperineal orifice being dissected. Now a large mesh, that's 13 into 15 centimeter polypropylene mesh is introduced, fixed to the Cooper's ligament. Then the people here, as you see, the lower part of the mesh is well plugged into the space of radius, at least 3 centimeter into the space of radius, because there is no fixation is done inferiorly. So this really prevents the recurrence of obturator hernia. Here you can see the pubic symphysis. This is the pubic symphysis. One tack is placed over the Cooper's ligament. This is the site of the obturator foramen, and this is the lower part of the mesh. At the same time, you have to take care that whenever you close the peritoneum, the mesh doesn't get lifted up. So raise a very good flap of the peritoneum. That is, during its closure also, or during peritoneal approximation, see that the mesh doesn't get lifted. So this is the site of the obturator foramen. You have enough of the mesh, at least 3 to 4 centimeter of the mesh below the obturator foramen. So this prevents the recurrence rate of obturator hernias. So now the question is a routine exploration of the obturator space during a laparoscopic repair, let it be a TAPP mesh repair or a TP mesh repair, is it required? So there is a TP mesh repair being done. On the right side, the space of radius is dissected. So there you can see the accessory obturator artery there over the Cooper's ligament. As you go laterally, dissecting the space of radius, the first structure normally what you see will be an obturator nerve. So be very gentle. There is no use of energy sources here close to the obturator nerve. So those tissues, the flimsy tissues, you can use an intermittent diathermy. So that's the normal obturator space. You're not seeing any wide obturator foramen or any fat herniating in this area. So that's the obturator now. There's the entire myoperineal orifice. So whenever you're placing the mesh here, see that it is this peritoneum here is not herniating. That peritoneum is not herniating behind the mesh. So there is one paper which is searched that the obturator hernia as a frequent finding during laparoscopic pelvic exploration. So this was a retrospective study that was conducted in Israel for 5 years. That is from 2003 to 2007. So here they have looked out for or searched for an obturator hernia where they are operating for inguinal hernia in all cases. So the number of patients were 293 in 5 years who had bilateral or a recurrent inguinal hernia. The recurrence following, it was basically a recurrence following an open surgery. So 96% of the patients were male, on contrary to the literature which shows that it is more common in female. 20 cases of obturator hernia was detected among 293. 18 was for bilateral and 2 for recurrent hernias. And also the average operating time with the patients with obturator hernia doesn't differ much from the average operating time. So there was no complications. The length of hospital stay was the same. So with this paper, we can conclude that the obturator foramen should be explored. This is to prevent the recurrence because of an occult obturator hernia or a missed hernia, what we can say. following an inguinal hernia repair. And the true incidence of obturator hernia has increased because of the advent of laparoscopic procedures than reported in the literature. If the obturator hernia is found, let it be a preperitoneal fat as a content, or a paravesical fat as a content, or as a fat plug or a lipoma, or you find a very wide obturator foramen, it has to be repaired using a mesh which is fixed well to the Cooper's ligament and the pubic symphysis, and see that enough of the mesh, the flat mesh or the free end of the mesh, is not rolled up and it is pushed well into the space of Retzius or the cave of Retzius. Thank you very much.
Dr. Shenoy, that was one beautiful presentation and some very beautiful videos. I must congratulate you. That was a very nicely shown talk. It was in fact so nice that I believe there are no questions. Dr. Mittal, what would be your comment? Sir, you're muted, Dr. Mittal. Dr. Mittal, you've muted yourself. Yes, sir, please, few words from your end.
I would like to congratulate Dr. Ganesh Shenoy on tackling a very difficult hernia very nicely and explaining in detail the anatomy and the way to deal with it. I have one question. Is it necessary to pull out all the fat from femoral hernia and the obturator, femoral canal and the obturator canal in all cases, or you will go after them only if you suspect a sac to be there?
Sir, by laparoscopy, the definition is any herniation of any extraperitoneal fat or a paravesical fat into the obturator foramen is considered as an obturator hernia. So most of the times when we explore the obturator area routinely, you don't see any fat herniating into the obturator foramen. As I shown in the video, there was no obturator fat. When I explored showed the video of obturator space being explored routinely, there was no fat which was herniating into the obturator foramen. So high index of suspicion is required. When you start dissecting the space of Retzius, go laterally. If you find any fat which is herniating into the obturator foramen, or you find an obturator foramen, those fat has to be reduced. Because once you place a mesh, we are not going to fix the mesh inferiorly. So this herniated fat remains behind the mesh, and this fat may pull up the peritoneum in future. It can draw in the peritoneum because of the increased intra-abdominal pressure or any other causes. It can draw the peritoneal sac, and then in future the patient may not present with a visible swelling, or we may not appreciate a palpable lump, but the patient may just present with pain. So I feel that routinely obturator space has to be explored. It doesn't take much time. As you cases increase, and any suspicion of fat herniating into the obturator foramen needs to be reduced, because anyway you are covering it with the mesh. The mesh covers the entire malperitoneal orifice of Richard. So the chances of recurrence or the post-operative pain because of the missed or occult obturator hernias will be minimized.
Okay, good. Thank you. Thanks. Thank you very much, Dr. Shenoy.
Yes.
Any more questions?
No, there are no questions from the audience as such. So I think we can move to the next segment. We have a change in sequence here. So the topic of internal hernias would be taken prior to the other two topics. So I invite speaker Dr. Rajesh Kula sir, and I would invite Dr. Yusuf Ashfaq to chair the session. Dr. Rajesh sir, over to you.
Can you see my screen?
Yes, sir, we can see you.
Yes, sir. So we can see you very clearly.
Okay, can you see my slide?
No, sir, not yet.
No, not yet.
Can you see now?
Yet. Yes, we can see your desktop now. Yeah.
You can see my desktop?
Yes, sir.
Yes.
You can open
Yes,
the file.
we can see your desktop.
Okay. Can you see the slide now?
Yes, sir. Yes.
Yes, we can.
Yeah. Can you see that?
Yes, sir.
Yes, we can see.
Yeah. Thank you very much. And I thank Dr. Ramesh Agarwala for arranging these multiple series of hernias. I thank Dr. Yusuf. Good to see you there.
Yes.
And I bring greetings from my Max Institute of Laparoscopic Endoscopic Bariatric Surgery Center. A very unusual topic has been allotted to me by Dr. Ramesh Agarwala. I'll try to do my best justice to this. Now, there are three types of hernias. You can have external hernias, you can have diaphragmatic hernias, and you can have internal hernias as such when hernias are concerned. Now, external hernias are the hernias which occur through body wall. They produce a visible, palpable swelling which is covered by skin. As you can see, the different variety. You can have epigastric, incisional, umbilical, inguinal, femoral, Spigelian, different kind of hernias. Then you can have diaphragmatic hernia, which can occur as a diaphragmatic hernia or as a hiatus hernia. The diaphragmatic hernias are congenital, which could be through the foramen of Morgagni, which is anteriorly placed, or it could be through foramen of Boctelet, which is posteriorly placed on the right side. The acquired diaphragmatic hernias are hiatus hernias, and I think we are not going to discuss these hiatus diaphragmatic hernia because they are a big topic in itself. So what today we are going to discuss is the true internal hernias. Now, these internal hernias are invisible, they are impalpable, and they are not covered by skin. By definition, these are the protrusions of abdominal viscera, most commonly the small bowel, through an intra-abdominal aperture without traversing the facial planes. So that is the important definition, that you can't feel them. They are not visible to us and they happen internally. Now, these internal hernias, they usually present as bowel obstruction, and they are the cause of bowel obstruction in approximately 0.6 to 5.8% of all small bowel obstructions. But it is to be remembered that if the obstruction is because of internal hernia, it is associated to almost 31 to 50% mortality, especially in acute events, because the diagnosis is delayed in these cases. Now, the internal hernias could occur through the natural defects, or they could occur through acquired defects inside the abdomen. Now, if you see the natural, naturally occurring defects, the internal hernia through natural defects, they are rarely suspected preoperatively, and normally, most frequently, they are diagnosed only intraoperatively when you have gone in for relieving the obstruction. Now, these naturally occurring hernias could be a paraduodenal hernia, which could be left paraduodenal or right paraduodenal. Now, this is the left paraduodenal and this will be the right paraduodenal. Or it could be through the foramen of Winslow hernia. It could be a pericecal hernia around the cecum. It could be a sigmoid mesocolon hernia related hernia. It could be transmesenteric hernia, or it could be transomental hernia, or supravesical and pelvic hernias. Out of these hernias, paraduodenal hernias are the most common ones, and they form almost 53% of all the natural occurring internal hernias. and then comes the pericecal, and then the other rare hernias. So these hernias are really rare in occurrence, and the symptomatology of these hernias depend upon the individual region where they occur. The problem is the diagnostic dilemma, because they do not present with any specific symptoms. The symptoms are vague, and the examination is non-contributory other than the evidence of small bowel obstruction. The high index of suspicion and early CT can help in the diagnosis, where you can see a U or C-shaped distended intestinal loops. Now, the symptoms depend whether you have a left paraduodenal hernia or a right paraduodenal hernia. Left paraduodenal hernia is more common and occurs in 75% of all paraduodenal hernias. Normally, these hernias, they occur because of defect in the rotation of gut when it is occurring. And on the left side, it is the congenital fossa of Lenzert, which occurs in 2% of patients at the duodenojejunal junction behind the inferior mesenteric vein. And these patients normally present as postprandial pain. On the right side, which is about 25% of all paraduodenal hernias, this occurs through the Waldeyer fossa, which is less than 1% behind the superior mesenteric artery, and this also gives, it presents, and it is behind the superior mesenteric artery and presents as chronic postprandial pain. So in these patients, basically you have to really have high suspicious index of suspicion and get a CT scan done to diagnose these conditions. The important thing to remember is that the mortality in these cases is very high due to delay in diagnosis and septic complication of bowel ischemia. So that is why you have to act as quickly as possible. The more important and common entity which we see in internal hernia is through the acquired defect, especially after the much common laparoscopic bariatric surgery, especially the bypass surgery. These hernias used to be rare when this obesity surgery was being performed by open technique because of the formation of intra-abdominal adhesions after open surgery. But since the advent of laparoscopic surgery, when these techniques are done laparoscopically, the intra-abdominal adhesions are much less, and the bowel has much more chances to move around inside. Now, there are three classical defects. One is the transverse mesocolon defect, and this used to happen when a retrocolic anastomosis of gastrojejunostomy was done, which is now done rarely because now we prefer to do a anticolic gastrojejunostomy. The elementary limb comes in front of the colon, so prevent any hole in the mesocolon to prevent a mesocolic defect and a mesocolic hernia. So now we are faced usually with two defects, which is one, a jejunojejunal defect, jejunojejunal mesenteric defect, where you create a jejunojejunostomy, and second is the Peterson defect, where the defect is between the mesentery of the elementary limb and the transverse mesocolon. So these two defects are developed in all cases of Roux-en-Y gastric bypass surgery, laparoscopically done, and it is important to close these defects at the time of surgery to prevent development of these hernia. But even closure of these defects do not prevent hernia formation. Now, other procedure which can lead to acquired internal hernias are the bowel anastomosis done for resection anastomosis of the bowel. Even hepaticojejunostomy done during a liver transplant and Whipple procedure creates internal hernial defects. Ostomy formation also creates a internal hernia. So during all these procedures, it is imperative that we close these defects to prevent development of internal hernia. So this is the classical Roux-en-Y gastric bypass, and these are the classical two defects through the jejunal defect as well as between the elementary limb and transverse mesocolon. Now the incidence through these defects after LRYGB is about 1.8 to 7.6%, and the herniation of long segment of bowel can occur, and it can lead to catastrophic ischemia. We have seen almost all the bowel herniating through these defects and going 360 or even double twisting to cause ischemia of the whole gut. Now, these patients, they present with the postprandial abdominal pain, symptoms of obstruction. The important thing to understand is that if a patient of post-Roux-en-Y gastric bypass has lost significant amount of weight and comes with abdominal pain, there are two things to be ruled out. One is a anastomotic ulcer, and second would be internal hernia. So one must always suspect. So the high index of suspicion is the most important thing in diagnosing these patients. So even if these patients may not have actual symptom of obstruction, especially if the herniation is through the Peterson defect, the patient may continue. There may not be any dilatation of the loop. There may not be any complete obstruction, but still there may be internal hernia. And it is important to intervene when these patients are having pain rather than waiting for them to come to emergency, because once they come in emergency, then if the obstruction continues and if exploration is delayed, the effect may be very catastrophic. Now, the diagnosis, if you suspect pain and if you have suspicion of internal hernia, CECT is the gold standard. So we must do it. Although even after doing CT, about 20% cases, the diagnosis can be missed on CT also. So if you have a very strong suspicion, doing a diagnostic laparoscopy will always be a good decision to go in. Mesenteric wall sign is seen only in about 55% of patients who have internal hernia. So you must not depend on that. Once you go in, if patient comes as an emergency, you have to go in as early as possible because there may be a closed loop obstruction. And this leads to rapid evolution to strangulation and ischemia. During surgery, you have to reduce the bowel as safely as possible because usually bowel is distended, especially if you have gone in acute case. You may injure the bowel, so you have to be very, very careful. So you reduce the bowel, bring back the circulation, and always close the defect. Always inspect if you have herniation through one defect, always look at the other defect also and close that if it is patent. Overall mortality, if the patient presents in acute stage, may be as high as 50%. Now, this is a video of a patient who had chronic pain abdomen. He was scoped electively on a suspicion, and you can see it's a jejunal herniation. The bowel loop has herniated through the jejunal defect. And you can reduce the bowel. You will see when the whole bowel comes out, even the JJ anastomosis can herniate. And once you reduce, the obstruction is relieved in front of you. This is the best way to do it at this stage. So if you have suspicion clinically that the patient is having pain of postprandial pain and there is significant loss of weight, this is the best time to go in, reduce the hernia, and close the defect. But it doesn't happen. Always the patient may come in this stage. Now, this is the bowel is in pre-gangrenous state. You can see that the bowel is bluish, but not totally gangrenous. This is the herniation through the Peterson defect. You have to handle the bowel very carefully. And one of the way is to start from the ileocecal junction. You can see the cecum, that's the ileocecal junction. Start pulling the bowel from the ileocecal junction, go on proximally, and you can see the collapsed bowel which you are pulling. So gradually, as you go towards the herniation, it becomes dilated, and that is how you bring out the loop through the defect. And that's the JJ, and it has been reduced. And that's the defect through which the bowel had gone. This is the Peterson defect. You can see the transverse mesocolon above. That's the transverse colon. It is important to close this defect with non-absorbable suture and continuous suture to make sure that there is no further herniation. And it is very, very important. Although in primary surgery, if you close all the defects, still herniation can occur after the patient undergoes loss of weight, because the spaces can open up again. But definitely closure at the time. And now you can see the bowel has regained its viability. The color has come back. So we have saved this bowel from turning into a gangrene. But sometimes you can be very unlucky, and when you go in, you may come across this state. This patient came about 5 days after the symptoms. There was no way this bowel could be salvaged, so it was opened up. We excised the bowel, reversed the anastomosis by doing a gastrostomy. Luckily, this patient had about half a meter of bowel from the DJ and about 1.5 meters from the ileocecal junction, and we could anastomose and salvage him. But look at the amount of massive bowel resection which needed to be done to save this patient. And it is important to reverse the bypass whenever you do a massive resection, because that itself will maintain the weight of the patient. So important thing to keep in mind is that you should always carefully close all the mesenteric defects during laparoscopic RYGV. The internal hernias are rare hernias, and these hernias are difficult to diagnose. A high index of suspicion is always very, very necessary, and prompt surgical intervention is very important to save these patients. This condition is associated with high morbidity and mortality due to bowel ischemia and necrosis. So one must act quickly in these cases. Thank you very much.
Any question? I cannot see any question in the chat box.
Yeah, and even from the Docplexus, there are no questions as such. So, Dr. Rajesh, that was a very comprehensive and very nice presentation. The videos were very nice. I'm
Thank
sure
you very much. Thank
those
you.
moments would have been very challenging when you see such an abdomen. Dr. Yusuf, you have any comments on the same? Please go ahead.
Sir, the studies have shown that Peterson hernia is more common than jejunal hernia. So what's your experience among them?
Yeah, you see, what happens is, if you do not, there was a school of thought, and there are still 2 surgeons now who would say that whether you close or you don't close, the internal hernia can occur. So if you don't close any of the hernias, then you have more common herniation through Peterson defect. If you close jejunal hernia, then again, Peterson defect will happen. We found when we started doing laparoscopic bypass, we also thought that closing will not make any difference. and we took the easy path and not closing the defects. And after 2 years of our starting doing bypass, we started getting jejunal internal herniations. And then we started closing our jejunal defect. And after 2 years of that, we started getting Peterson herniations. So it is imperative to close both the hernias, both the hernial defects, to prevent, or if not prevent, to reduce the incidence of internal hernia in these patients.
And so in patients who have normal CT scan and symptoms of chronic obstruction or chronic recurrent obstruction, you go by diagnostic laparoscopy.
Yeah. You see, if the patient of RYGB comes with pain abdomen, recurrent pain abdomen, one is to rule out, as I said, a ulcer, ulcer at the gastrojejunostomy. So if once the ulcer is ruled out, if you do a CT, you see the CT has to be done during pain. Only then you may see features of internal herniation. Because many of these patients, they will have herniation, bowel will herniate and then come back to normal situation. So if the patient doesn't have any pain at the time of CT scan, the CT scan may be absolutely normal. The chances of picking up features of internal hernia on CT would be more if the CT scan is done during acute pain. If that also doesn't show and you rule out pain due to gallstone disease, you rule out pain due to ulcer, then only thing left is the internal hernia and doing a diagnostic laparoscopy. If you do not see any herniation of the bowel, but you see open hernial defect, it means the diagnosis was internal hernia. And it is imperative that you close those defects at the time of diagnostic laparoscopy. And we have seen that these patients, they get relief from their pain. So it is important to do a elective diagnostic laparoscopy in these patients of pain abdomen after RYC.
Thank you, sir. You have very nicely explained the internal hernias.
Thank you. Thank you. Thank you, Dr. Ramesh, and thank you, whole team, for conducting such a wonderful webinar. Thank you.
That was a very exhaustively explained internal hernia topic. We now move to the next topic of Spigelian hernia and other interparietal hernia. Dr. Imri Amil would be filling in for Dr. Danny Rosen, and Dr. Harmeet Paul Singh would be chairing the session. We have Dr. Danny here. Oh, fantastic!
Yeah,
so we have both the people here. Very nice.
Yeah, I will just introduce Dr. Imri. He's a young and bright surgeon, very enthusiastic about hernia surgery, and he's one of the leaders in Israel in surgical simulation and education. And please, Imri, play your part.
Okay, thank you. Hello, everybody. Thanks for having me. My name is Imri Amiel. I'm a surgeon from Israel, and in the next 15 minutes, I'll be talking about Spigelian hernia. The semilunar line was first described by Edwin van der Spiegel, a 17th century anatomist of Flemish origin and lecturer in the University of Padova, Italy. Yet the first description of a hernia through this area was documented only in 1764, more than a century after his writings were published. Each semilunar line extends as a curved line just lateral to the border of the rectus abdominis muscle from the tip of the 9th costal cartilage to the pubic spine. Anteriorly, in its whole length, it is reinforced by the internal oblique, by the external oblique, sorry, and posteriorly, for 3/4 of the way from the above downwards, it is reinforced by the transversus abdominis. As more and more fibers are joined to the anterior sheath, the posterior sheath becomes thinner and finally end midway between the pubis, between the umbilicus and the pubis, creating the semicircular or arcuate line of Douglas. The linea semilunaris, or the semilunar line of Spiegel, is not a mere line. Repeated dissection and surgical observation during the years have proved that the blending of the muscle layers and the poneurotic sheath is not accomplished through a sudden sharp line of demarcation, but rather through a broad zone extending to a variable distance from 3 to 37 millimeters in width. Spigelian hernias are usually located at the junction of the arcuate line and the semilunar line in the Spigelian fascia, where the fascia is at its widest portion. However, the exact location of the arcuate line is variable, which gives rise to the concept of the Spigelian hernia belt, located between the horizontal lines drawn just below the umbilicus cranially and the anterior superior iliac spines caudally, and is usually about 6 centimeters in length. The symptoms of small hernias are often obscure, and the diagnosis is difficult. This is especially true in cases where the hernia does not perforate the external oblique, and thus is interparietal in nature. Most patients complain of localized pain or discomfort at the site of hernia protrusion. Only as the hernia enlarges or perforates the external oblique to become subcutaneous in position, the patient will notice a bulge, which will also be palpable during physical examination. According to the literature, the reported incidence of Spigelian hernia ranges from 0.1 to 2%, with slight predominance in women. These hernias are generally small in diameter, with a defect typically measuring 1 to 2 centimeters. They tend to develop during the 4th to 7th decade of life, and up to 20% will have an acute presentation with bowel obstruction. Cross-sectional imaging or ultrasonography can be helpful in the diagnosis of hernia for patients with localized pain in the Spigelian belt and no palpable mass. As seen on the left side of the screen, a CAT scan shows intraperitoneal fat bulging just lateral to the right rectus muscle, covered by the external oblique aponeurosis. On the right side of the screen, a magnetic resonance view shows a different patient with a similar presentation. Keep in mind that the fat is now depicted in white and the muscles and fascia in black. According to the literature, because of high risk of incarceration, watchful waiting is not recommended when Spigelian hernia is found incidentally. Although surgeons may have different experience, and we rarely see this acute presentation. The initial step in an open repair is to confirm the location of the hernia. This can be challenging if the hernia is not palpable by hand. However, modern imaging techniques can overcome this challenge. After the skin is being marked with ultrasound guidance, a transverse or an oblique incision is made, and the subcutaneous tissue is explored if the hernia penetrates the external oblique aponeurosis, or if interparietal in nature, an incision of the fascia of the external oblique is made. The sac can then be excised or reduced into the abdominal cavity. If there's concern to the visceral content of the hernia, the sac should be open to allow its inspection. Following, a primary repair of the separated transversus abdominis and internal oblique muscles can be accomplished with either running or interrupted sutures, as only rarely recurrence has been documented in the past, even before the era of prosthetic mesh. Nowadays, most surgeons would prefer to reinforce the repair with a mesh. A flat sheet of prosthetic mesh can be placed either between the repaired internal oblique muscle and the external oblique, or in a pre-dissected preperitoneal space. The mesh is then secured with sutures or tacks placed circumferentially around the prosthesis. If the preperitoneal space has been dissected widely enough to allow large overlap of the defect, then no fixation is required. Once the prosthesis is in place and the above muscle layers are reapproximated, as in the non-prosthetic technique, and finally, the external oblique aponeurosis and is being sutured and followed by skin closure. Today, laparoscopic approach simplifies the repair in both the identification of the hernia site from within the abdomen, the placement of the mesh, and the results of the surgery. This can be achieved in different techniques. One is the IPON technique, with or without primary transfacial sutures, the extended view, totally extraperitoneal repair, and the transabdominal perperitoneal repair. This movie depicts the case of a 57-year-old female with past medical history of inflammatory bowel disease and a body mass index of 23.4, who presented to the emergency department in our institution in the beginning of this year, complaining of abdominal pain with a discrete bulge in her lower right abdomen with no clinical evidence of bowel obstruction. Her physical exam revealed a small, tender, palpable mass in her right lower quadrant of the abdominal wall without peritonitis. Her CAT scan showed what seemed to be a right-sided Spigelian hernia with incarcerated fat. She was then taken to the operating room. The operation begins with the inspection of the peritoneal cavity, identification of the hernia defect, and extraction of the omentum from the hernia sac using laparoscopic forceps and harmonic scalpel. As you can see, there's quite a lot of omentum which was inside the hernia sac. Once the sac content has been reduced, a peritoneal flap is open medially to the defect and widened sideways to accommodate a large enough mesh. Please pay attention to the arcuate line as it is being revealed in the upper left side of the screen. The hernia sac is then separated from the fascial defect. The defect is then closed in a primary fashion using a polypropylene suture passed transfascially using an endoclosed suture passer. An 8 centimeters wide, lightweight polypropylene mesh is then adhered to the fascia using absorbable tacks. Finally, the peritoneal flap is closed over the mesh using tacks. That's all. Thank you all for listening, and warm regards from the Sheba Medical Center in Tel Aviv, Israel.
Dr. Emil? Dr. Emil? Dr. Emil, can you hear me?
Dr. Imri?
Yeah.
Dr. Emil, can you hear me?
Dr. Harmeet is asking if you can hear him. Is he audible to you?
I don't think so. No?
Dr. Imri?
Emil?
Yes, I hear you.
Okay. Very nice presentation. Congratulations for that. I have one observation and one question. Observation is that to my younger colleagues, to have a high index of suspicion, because any pain, localized pain in that area, and any small lump, please have a high index of suspicion. Otherwise, you are liable to miss this interpretal hernia, and they are very liable to obstruction and strangulation. My question to ML is, any predisposing factors for such hernias and any surgery which predispose to such hernias? Dr. Emil?
Can you repeat the question, sir?
And any predisposing factors for such hernias to occur, or any previous surgery which can predispose to such hernias?
The current case, she had an open small bowel resection many years ago in a midline incision, which had apparently no connection to the Spigelian hernia.
I think we should also recognize that some of these so-called Spigelian hernias are actually trocar site hernias, because this is quite a common place to place trocars, and some of them are quite large and not.
That was why I asked this question. Some studies have reported high incidence of these hernias post-laparoscopic surgeries. Right.
So we have no questions as such from the Docplexus side, the audience side. So, Dr. Harmeet, can we, in that case, move to the next segment?
Sure. Thank you.
Okay. So now we move to the last leg of the session today, and I hereby invite Dr. Parth Sarthi as our speaker and Dr. Atul Agarwal as the chairperson for the topic of CT anatomy and management of primary lumbar hernias. Dr. Parth Sarthi, over to you, please.
Very good evening to all. I'd like to thank the president and the secretary and office bearer of HSI, and Dr. Pallavi and Dr. Vishal to giving me this opportunity. And I'm going to talk on today. It's one of the very rare hernias. It is called a lumbar hernia. And I'm going to show you CT anatomy and then a laparoscopic management of lumbar hernia. So I'm going to share my screen. So this is the CT anatomy of lumbar hernia. So usually we know we are very well versed with the ventral hernia, all type of midline and lateral ventral hernias, and this comes under the category of dorsal hernias. And this is the hernia occurs between the inferior to the 12th rib and superior to the iliac crest. So this is the reason, this is the region the hernia is occurring. So this is called dorsal hernia, and this is an unusual hernia, and it accounts for around 1.5 to 2% of abdominal wall hernias. And nowadays we are seeing frequently lumbar hernias because the orthopedic surgeon started doing anterior fusion of lumbar spine in a lumbar approach. And then after radical nephrectomies and transplant surgeries, so the lumbar hernias is coming more. And it is referenced as a pseudo hernia also. In my series, a lot of pseudo hernias. And this is because of the lateral bulge, the result of intercostal nerve injury, T11 and T12, and the subsequent paralysis of the flat muscle. It will produce a huge hernia. And it's called pseudo hernia. There will not be any obstruction, but it is pseudo hernia. And generally, these hernias are very difficult to treat. And way back in 17th century, the first report of strangulated lumbar hernia came by Roberton. And in Petit, John Louis Petit, in 1783, and he described the inferior lumbar space, otherwise called inferior lumbar triangle, and in the 17th century. And in 1866, Grinfeld described the superior lumbar space. And a lot of the description came for traumatic acquired lumbar hernias. For the first time, laparoscopic approach of lumbar hernias described by Burek and Parascandolo in 1996. That is the first report of lumbar hernia. That is also traumatic lumbar hernia. Before going for the CT anatomy, this is an illustrated picture of superior lumbar triangle is shown in this picture. So we got to find out three important structure. One is the 12th rib, and erector spinae muscle, and internal oblique muscle. So this 12th rib will be the superior border, and then erector spinae will be posterior, and the internal oblique will be the anterior. So this is the three muscle is forming the triangle. Usually the transverse abdominis form the apex of the floor of the triangle. And usually this triangle seen in 85% of the one study shows it is only 82% of the patient humans the triangle is described in a cadaveric study. So when we are going for a CT to look out the superior lumbar area, so we have to concentrate on the 12th rib and the erector spinae muscle and the internal oblique muscle. So this is the three identification point of this CT findings. So now I'm going for a CT findings of the lumbar hernia. Thanks to Dr. Pallavi to share this CT video. And this is the video from Dr. David Lowry from Pasadena, California. And this was one of the very good description I could see. And so this is the dorsal hernia basically. So we are seeing the backside of the patient. And the entire back is mostly covered with the latissimus dorsi muscle. And it was shown in this picture as a yellow color. And then this is the purple will be the external oblique, and then blue will be the internal oblique. Once you cut this dorsal, it is superior triangle is basically covered with the latissimus dorsi muscle. And once it zoomed that area, so this is the 12th rib. And then this is some of the fibers of serratus anterior muscle. And then according to Dr. David Lowry, and quadratus lumborum is the main thing to identify in superior and inferior lumbar triangle, but it is not described in many literature. So this green color is the erector spinae, this is the internal oblique in blue color is marked, and then purple will be the external oblique. So we are concentrating on 12th rib, erector spinae, and the internal oblique. So this is the superior triangle. It is covered with the latissimus dorsi. And I'm going to show the CT anatomy of the superior triangle now. And you can see this is the erector spinae muscle on both sides, and this is the quadratus lumborum. It is marked in brown color here. This is the 12th rib, and then this is the latissimus dorsi. So now this is the triangle. So now this is the coronal view, and you get able to see this quadratus lumborum here, and then this is the 12th rib, and then this is the latissimus dorsi. So this is the superior triangle. So we are not concentrating, we are on ventral side and then flank muscle, but this is little posterior anatomy. So in this case, it is suppose superior lumbar hernia is present. It will be seen like this. So now you can see this, tracing the rib, and this is the tip of the 12th rib. This is the erector spinae, and this is the quadratus lumborum, and this is the latissimus. This is a normal side. You can see the latissimus dorsi will be like this, and then this is the hernial side, and this is the latissimus dorsi. So it is called ballooning of latissimus dorsi. It is called latissimus dorsi ballooning sign. And this is the erector spinae muscle and the quadratus lumborum, and this is the latissimus dorsi. So this is the colon, descending colon is coming into the, and the fat is coming through the hernia. So this is the coronal view, and again 12th rib tip is seen here. This is the quadratus lumborum, and this is the lat muscle, and this is the hernial side. So this is the normal area or normal triangle. This is the lumbar hernia. This is the superior lumbar hernia. Going to the inferior lumbar triangle, otherwise called a petit triangle, and here the anatomical boundaries is latissimus dorsi and external oblique muscle and the iliac crest. So this iliac crest here, it is the internal oblique from the floor of the triangle. Internal oblique will be the floor of the triangle, and here again I'm going for a CT anatomy. So this is the inferior lumbar triangle. We have to concentrate on iliac crest and the external oblique and internal oblique. These three muscles you have to concentrate here. And this patient had a hernia here, and we are well versed about this ventral anatomy, and then the lateral flat muscles, transverse abdominis, internal oblique and external oblique seen nicely. And so these are all the triangle, inferior triangle, lumbar triangle. So this is the area. And this is the thin area connected. It is the iliac crest, and external oblique will be purple color, and then this is the latissimus dorsi. You can see it is covering back, entire back, and then this is the internal oblique will be marked here with a blue color. So this is the thin, upper neurotic area will be connected. So this is the internal oblique. This internal oblique, this ruptured, then this will form a hernia. So here also the quadratus lumborum is there, and so according to him, Dr. David, quadratus is the important structure to identify in all both superior and inferior lumbar hernia. Again, the coronal view. This is the external oblique muscle, and you can see the iliac crest here. This is the internal oblique. Color is marked as a blue, and then here the part of small quadratus lumborum muscle is also seen here. So this is the internal oblique area, inferior triangle, inferior lumbar triangle area. This is another view. Iliac crest is seen, sagittal view, and this is the rib, and then this is the internal oblique, and then this is the latissimus dorsi muscle, and this is the some external oblique also seen here. So it is very, after this, we can able to find out very easily. Suppose if it is the lumbar hernia is there, so how the anatomy is changed. Again, axial view, quadratus lumborum on both sides, lats, and then external oblique. And then now you can see here, the internal oblique is disrupted here. And then this is the erector spinae, this is the lat muscle, quadratus lumborum, and external oblique. So this is the inferior petit hernia, inferior lumbar hernia. Here you can see it is well covered. Here all the muscles. Usually the colon and the extraparietal fat of tissue will be the content. So this is the CT view of identifying the inferior lumbar hernia and triangle, and then superior lumbar hernia and the triangle. So again, the external oblique muscle and iliac crest, and then this side, this patient had all here the sagittal coronal view is a lumbar hernia presence. So coming to the laparoscopic management, and this is the team setup for a left side lumbar hernia, maybe superior or inferior. And usually we keep the patient in left lateral with the sandbag below here. The surgeon stand on the right side, and monitor will be on the left side of the patient, and assistant will be on the left side of the surgeon. We used to make a 3-port in the midline, and then we could enter. So this is the midline port, 10 mm camera and 5 mm. A working port on either side, so the triangulation is will be there for good for suturing. And sometimes we put an extra port here, and we have to concentrate. We have to mobilize the colon and sac to be mobilized. So initially the intra-abdominal adhesions to be dissected first, then we'll expose the hernial and its contents, and sac to be contents to be reduced, sac to be excised, the facial edge to be cleared, and then we do closure of the defect. And sometimes, if it is a difficult closure, then we keep a large mesh. The mesh tube covers almost 7 to 10 centimeter all around, and usually it will cover the costal margin to the iliac crest, and then psoas muscle to the intra-abdominal wall. So such a large mesh we require. Usually we keep a composite mesh, and then we fix it with the suturing, intracarpal suturing, and taker both. So this is the left lumbar hernia. The patient is in left lateral decubitus position. Bowel is being displaced, and then the adhesion is there on that side, and that is the colon till we are not reaching the hernial site. And now it is a hernial site is being seen. So we try to reduce the content of the hernia. And usually it will be asymptomatic for a long time. And if it is bigger, defect is bigger. So we're pushing from outside, we could be able to reduce some of the content. And then we started dividing the lateral attachment of the colon. Line of told is being dissected. And we have to mobilize the colon medially. And we have to expose the psoas muscle. And we have to come up to the quadratus lumborum muscle. So now this is the spleen we dissected, up the costal margin dissected. Now we could see a lot of content. And this is only the peritoneal attachment, just lateral peritoneal fold. I'm dividing now. And so that it will give a good view to take out the content. We tried with this view, the camera is going inside to take out the content. We find difficult. So that is the colon is still there. So maybe the congenital type. So we are just widening the opening. Now it is camera is taken into the defect, and we could able to reduce the sac. And if you find out, if you reduce the sac, the content will come out. No need to separate, take the colon separate and then sac separate. Because nothing else is there, only the sac. If you take out the sac, the entire content will come out. So now we are, entire sac is being taken out. So now the inferior muscle is being the view, and this is the inferior pole of spleen. So we are going into the costal margin area posteriorly, and superiorly we go onto that level. And then we mobilize the colon completely. We expose the entire psoas muscle. And when we come down, we have to be careful about the pelvic nerves and the ureter and the gonadal vessels. And sometimes the iliac vessel to be taken care. So this is the ureter is being identified, and then all the attachment, lateral attachment is being released. So we need to keep a larger mesh, and see this is the ureter. Ureter is down. That is the ureter, that is the psoas muscle, and the gonadal vessels is also being separated. So we exposed, we push the colon medially, and we expose the quadratus lumborum muscle. So this is the defect. It is difficult to suture the defect. Now you can see almost 10 centimeters all around the defect is being mobilized. And this is that large mesh, composite mesh. This is the Medtronic, Covidian mesh. It's a Paratex polyester with the collagen film covering mesh. And we used to take a transfacial suture, 2 or 3 minimum, and then it is being taken out. Our preference is intracorporeal suturing, and for any lateral wall hernias or flank hernias, very difficult to positioning the mesh in the initial period. So we, transfacial suture, and then taker is ideal one. We fire the taker, and in between we suture also. Usually this is the secure strap. 25 pin will be there. There is no anchor, 25 pin, and then 3 transfacial suture is already taken, and then multiple intracorporeal suturing is also being done. So the idea is, if it is a defect closure is possible, we can able to close the defect. And most of the primary hernias is difficult to close the defect. If it is acquired hernia, traumatic or paralyzed muscle, so that it is easy to close, and primary hernia is difficult. So we used to keep large mesh, almost 10 centimeter, covering all around should be there. So again, the colon is being repositioned, and then this ends the procedure. So this is another case. This is the traumatic one. and this is the drain site, flank. You can see this is the iliac crest, just above the iliac crest. It was there, and then this case E-tip is being done. And our approach is we reach the sublate space with the OptiView trocar, and this is nicely entered the sublate space, superior rectus muscle and the post rectus is down, and all the attachment is being divided. And after that, we put a 2 other port for our working. So this will give a almost 60 to 70 degree angle. So suturing and then this fixation is ideal. So here lateral linear semiluminaris is released, and then TA muscle is exposed. I'm going to fast forward for want of time. And so now the TA muscle is being seen nicely, and it required a TAR so that TAR and posterior component separation. Now the TAR is being done, and TA muscle is pushed up. So this is the posterior component separation is being done. Again, TAR is continuing to the costal margin towards up, and then now we are reaching the site of the hernia. The site of the hernia is reached. Now we are taking out the content. Here also the same, the sac to be excised, and then content will come along with the sac. The same principles, and so now almost partly it is reduced. So now it's completely the content and the sac is being taken down. And most of the time the acquired or traumatic hernia, and we can able to suture it. The paralyzed muscle will be there. Otherwise, this is called the pseudo hernias. This is the common. Nowadays, we are getting a lot of pseudo hernias, lumbar, traumatic acquired lumbar hernias. So this is the psoas muscle. It's exposed. We mobilize the content medially. So we should keep around 10 centimeter covering all around. So here we use the PPT suture, a polybutester locking V-lock suture, number 1 size. And so E-tape, this is a very good suture, locking 1 non-absorbable. Even though it looks big defect, it is easy to approximate. So it's completely defect is being closed, and then large mesh, polypropylene mesh is being kept. And you can see it should covers almost below the iliac crest level and above at the costal margin level, and then you can see it's covering up to the quadratus lumborum area. So that is the center of the mesh we fixing at the level of the defect, and here to minimum 3-4 intracorporeal suturing is enough, and then it's being drain is kept, and then it is done. And we are seeing a lot of paralyzed muscle due to the T11, T12 injury. And here the pseudo hernia, the lot of very high rate of failures. And some author advised sandwich repair, that is the open mesh repair and then laparoscopic IPOM. So combined both mesh repair is required to prevent the recurrence. This is one of the case, and the patient had a trauma, and then you can see very large one from costal margin to the pubic crest. And this is again we did a IPOM. This case we did the online laparoscopic IPOM, and you could see laparoscopically huge defect. This is the liver. The entire colon, right side colon is within the defect. This is the cecum, small bowel, and then we take out the sac. We reduce the content, and since it is a very flappy muscle, we just take out the skin. So we did a open and the flank, and then we suture the defect. We cut the excess skin is being trimmed out, and then after suturing it will be like this inside, and then large mesh. Mostly this kind of hernias will require 30 by 20 centimeter composite mesh. Again, this is the paratex mesh, 30 by 20 centimeter, and we fix it with the anchor, secure strap, and then intracorporeal suturing. So, dear moderator, I like to conclude the lumbar hernia is a rare entity, but it can be treated successfully by laparoscopic method. And intraoperatively, the mesh to be placed to cover wide coverage of the hernial defect. And if you are not closing the defect, it should cover 10 centimeter all around. And if you are able to close the defect, 5 centimeter is enough. and mostly it will stretching out from the costal margin to the iliac crest and the anterior abdomen, that is a rectus, to the psoas muscle or erectus spinae muscle. The thorough anatomical awareness of the flank region is very, very important to avoid the damage to the important structures such as the ureter, pelvic nerves, and the gonadal vessel and other important vascular structure. The CT anatomy, and we are not much interpreted with the CT anatomy, but if you know this 3 identification structure for each triangle, so we could able to identify the hernia easily, and then it will give a very good thorough information when we are going for a laparoscopic approach. So laparoscopic repair is favored due to the reduction of morbidity and length of stay, so it can be done successfully for a lumbar hernia. With this, I'll finish. Thank you so much.
Thank you very much, Dr. Dr. Adul, sir, over to you. What would be your remarks on the same?
Yeah, it's very, very interesting, and the anatomy shown was really very nice, especially the CT images. One question, basically, in the anatomy of the superior triangle, you showed one of the boundaries is 12th rib. For that anatomy of the lower triangle, one of the boundaries was iliac crest, the Pettis triangle and the above one. So when you're putting the mesh, you said to cover from the 12th rib to the iliac crest. As far as the hernia principles go, it should be beyond that. So how do we deal with that problem? Because as for the anatomy of the hernia itself, the defect itself should be basically one of the borders for the superior triangle is 12th rib. So if we cover from 12th rib to iliac crest, we are not going beyond the boundary. So that's why I wanted to know, how do you deal with that?
So in the video I showed you, the spleen is mobilized, medially. The mesh is going almost, above the level, almost in the costal margin. Almost not at the costal margin, it's going above. So we have to cover, the 1 or 2 centimeters.
You go up to the diaphragm, basically, cover a bit of the diaphragm as well.
Yeah, almost.
Upper superiorly, the pelvic brim as well, beyond the iliac crest itself.
Yes. That's why we are looking for the ureter and the external iliac vessel and the gonadal vessel.
Yeah. Thank you.
Yeah. Basically, it is covering both the triangle and in our series in GEM, the primary hernias are a little rare. We are not getting much, but the acquired hernias we are getting more.
Very interesting. Thank you very much.
Thank you.
Sir, I have one question to the speaker and to the chairperson, both of you. We now are coming across hernias from the sites where the bone has been harvested, iliac crest, like orthopedic interventions. Any comment or any insight into the same, how the management differ, or it will be the same?
But it is the same. It is the same. And the only thing, you have to go inferiorly more.
Okay. What about closure of the defect or even attempting it?
Yeah, if it is it is called due to the surgery, comes means some part of nerve injury also will be there. So it is easy to suture. Or sometimes if it is a defect is bigger, we can inject the Botox injection. It will paralyze the muscle. Then you can attempt the suturing of the defect. It can be done by open method. It is here hybrid technique is very well acceptable. You can go for a open closure of the sac, open excision of the sac and closure of the defect, and then laparoscopic. That is very well accepted in flank hernias.
Okay.
I have one comment regarding these all these rare hernias. I think the common denominator is that as surgeons we are very lucky to live nowadays, because I think there are 2 factors that really help us and really change the scene from what we used to do 20 or 30 years ago. One is imaging, and the second is laparoscopy. I think with imaging, we can diagnose most of these rare hernias, which are really obscure and small, and with laparoscopy, we can access them and without the need to go through major muscles and large openings, because most of them, except for maybe the humongous lumbar hernias with the denervation, which can be very challenging, most of them are quite small and bothersome and can be dangerous. And with laparoscopy, you have good access and very good modes of repair, and I think that's why we are lucky.
Yeah, correct.
Sir, allow me to ask a question from Dr. Ashwin Tangavelu. This is for Dr. Partha Sarthi. Instead of doing the E-type repair from the retrorectus space, wouldn't it be better to put the ports lateral to the linea semilunaris and do the same repair and avoid a TAR?
See, it is the coverage. No, we have to cover the mesh to the anteriorly also. It should be covered nicely. And if you go there posterior to the defect, we can dissect easily. The anterior coverage will be difficult. So we need to cover the defect all around, the hernia all around. So that's why I thought it is a posterior component, and then TAR with the posterior component.
A wider plane. Yeah. Now there are a few more questions. Okay, please go ahead. Yeah.
One question I have: can you put the tackers in the quadratus lumborum without any harm?
Yeah, usually we don't fire the taker on the psoas muscle and lumborum. Only that we try to suture that area. Any muscle is there, try to suture it, because suture will hold nicely better than the taker. Usually the flat muscle, oblique muscle, we can able to fire a taker. When you go retroperitoneum, quadratus lumborum or a psoas muscle, my advice is for a suturing, intracarpal system.
Okay. We have a question regarding internal hernias. Can suturing of the serosa of the distal elementary limb to the abdomen wall, parietalizing it basically, might stop the hernia formation? This question is asked by Dr. Abhishek Singh. So, parietalization of the bowel to prevent the hernia. Any comment from anyone, please?
If I can relate to that, I don't think that suturing the bowel to the peritoneum can last for long, because the bowel is moving all the time. So I think we should concentrate on the holes themselves and close the holes, and just fixing the bowel will not last.
Perfect. Point taken. There is another question. Are there any guidelines for treatment for salvage of mesh infection in ventral hernia repair? A very broad question, actually. Maybe a short answer by any of the speakers or the chairpersons present, please. Dr. Ramesh? A short comment. Sir, you're muted.
Can you give me the question again, Vishal?
Yes. So are there, one of the viewers has asked, are there any guidelines for treatment or salvage of mesh infection in ventral hernia repair?
Oh,
very broad question.
The first thing is you have to prevent. That's the biggest thing.
Yes.
So prevention is the biggest thing. You should see that it should never happen. And as we've had in our previous talks also, that, it should be the first case on the list, change glove, don't let the mesh come in contact with the skin. So these are all things which we need to follow. But in case you have a mesh infection, then what you're going to look at is you have to look at, you have to get a CT scan done, send the swabs, give antibiotics, try palliative measures where you can conserve the mesh. And if they all fail, then you have to take out the mesh. And depending on, you can take it out by open surgery or by laparoscopic surgery. If you can do it by laparoscopic surgery, it's better, because if the hernia recurs, then you have intact planes there to repair the hernia again. But if you've gone through the open approach, then you don't have those planes to repair again. So it's a very broad topic, and I think in the previous webinars we have we've tackled it very extensively. But that is in short what we can do about mesh infection.
Thank you, sir, so much for that answer. There is another question, little offbeat from the topic today. The question is the use of mesh reinforcement necessary for giant hiatal hernia surgery? So not the topic for the night, but I think so. Maybe a lines or two. Dr. Yusuf, you're smiling. I think so. You want to say something?
Again, a very debatable topic, and it's a very broad topic.
Yes.
And
two-line answer. Yes.
For small hernias, mesh should not be put.
Yeah, large giant hiatal hernia.
So it is again not a consensus, and there are people in pro that we should put mesh, and there are groups that say that they should not be put. So I think there is no clear consensus.
Okay, point taken. I have one question. It's open to house. When you're operating one particular hernia, be it a groin hernia, for example, and you've discovered that the patient has an obturator or a femoral hernia, would you put another code of surgery, or you'd just go with the same thing that you've already done? Because effectively the mesh is covering everything. What is your take, or what does the house say? Please.
See, can I come in? See,
please, sir, please.
The treatment is same, as you rightly said. Now, if you want to charge the patient more, you can come and say the patient that you fix up 2 hernias. So that is the economical point of view. But see, the Supreme Court has said that if you've not discussed that treatment before, and if you find something else, and if it is not life-threatening and you fix it up, then you might be liable in the court of law. So you cannot repair something which is not life-threatening if you have not taken prior permission. So, you know, there are 2 sides of this. So if you try to make money and if they take you to the court, you are done. So I think it's preferable that you don't overcharge the patient. You just make a note that this was seen and it was treated. That's it. And inform the patient that it was done. And if you can add a word or 2 that I am not charging you extra for this procedure, he will keep on singing your praises outside, that what a good surgeon he is. He's done 2 surgeries at the cost of 1. And he may send you some more patients.
Right.
I think that just to comment on that, I think that the basic principle of doing a groin hernia repair is covering the whole myopectineal orifice. So how are you justified in charging something extra for what you intended to do at the first instance? Doesn't matter if he has an obturator hernia or he has a femoral hernia, or that's different if he has an umbilical hernia, because that may be in some cases you might find it there, or you may have it. But in a groin hernia, I don't think it is justified for us to do whatever you are intending to do in such a case, because the intent of surgery is covering the whole myopectineal orifice.
Siddharth, I agree with you totally, but there are some salesperson in our community also who would sell anything on earth. And
I think we will not be giving a right message to them.
Yes, that's what I'm saying. So you shouldn't do it. So, you know, the thing is also, it's not ethical. That is one. That is there. And if you try to do it, you might be caught and you might be, liable also. So I don't think, I agree with you, Siddharth, totally.
Makes sense. Dr. Siddharth, thank you for the nice ethical point that you made. An offshoot to what Dr. Ramesh said, that it so happened that we discovered, like we had a working diagnosis of some hernia, and we find one more hernia, indirect, direct, both, for example. And when we put that on paper and when we treated, we had some queries. So these days, before the surgery, what now I do is I always tell them that area is known to have more than one hernia. The surgery that I'll be doing covers all of them. So if in post-operative period, if I write that there was an indirect and direct or a femoral hernia seen and repaired, please don't get alarmed at why the new thing cropped up. So now I take a consent for a groin hernia repairs rather than just an indirect or a direct that way. So we've changed the term a little bit, and I think so. Maybe it will help.
I think that holds true in groin hernias when it comes to bilateral repairs also, because a lot of times clinically you don't find a bilateral hernia, but according to literature, a large percentage of patients have a bilateral hernia, even though they have not been diagnosed preoperatively. So in our setup, usually this is not exactly in detail what we are searching is, because we are already doing a whole coverage, but we definitely tell the patient that if we find the hernia on the other side, we would like to do it in the same sitting, and we take a prior consent for the other side also, because like we are doing a TAPP or a TEP, then you might find a bilateral inguinal hernia, and if there is a hernia, then definitely we would take the patient's consent preoperatively.
Makes sense. Okay, any other comment or question from any of the delegates? If none, then with the kind permission of our President President, sir, can we conclude the session?
Yes. So I'll just add a few words, Vishal. Thank you very much for moderating the session so well. I'm so grateful that you took over in such a short span of time. We have really missed Pallavi. Pallavi, she you know, did everything, all the background work for this program. But unfortunately, there was mishap with a relative, so that was there. Thank you, Danny, Amiel, Yusuf, and thank you, Siddharth, Ganesh, Vijay Mittal, Atul, Parthasarthi, Harmeet, Rajesh Kullar, and everybody else. I would like to place on record that this program came about because of the suggestion of our immediate past president, Dr. Sandeep Dave, who has been a very dynamic president. He was the president prior to me, and it was his suggestion that we should have a session of hernia. I never had this brainwave. It was the brainwave of our past president. I'm grateful to him. I hope he's hearing this, that this session came about because of him, and this session is dedicated to him. We are very grateful to Dr. David also, because Dr. David was he wanted to come on the program, but he had prior commitments. So he said that you can use my presentation, and he sent the presentation to be used. We are very, very grateful to him for allowing us to use his presentation. And I would like to thank all the delegates and also the Docplexus team, headed by Kritika and the others, for this excellent session. Thank you very much, and a very, very good night.
Thank you.
Thank you. Thank you. Thank you, everyone. We've actually stuck very nice.